onwards, I think we'll move on to the next talk by Dr. Avnindra Gupta. We'll keep having discussions in between just to make it more exciting. Yes, Avnindra, can you share your slides
Yeah.
and tell us about selecting? What are your tips of selecting a biosimilar? Are you wedded to? My honest question would be: what is the place of biosimilar in today's market? Are you still wedded to the Lucentis and Eccentrics or Aflibercept, or you are this thing to use biosimilars in every patient, even your own relative? Yes.
So, uh, thank you, Sipla, and thank you, Dr. Lalit, for giving this opportunity to talk about selecting a biosimilar. At the moment, it's a tough question because we don't have much experience about Vizumab. We have a lot of experience about Razumab. So actually, this question is difficult to answer at this stage. Uh, with the various pharmaco agents coming into practice, anti-VEGF has become the mainstay of treatment in diseases like DME, ARMD, and RVOs. Various anti-VEGF which are available in the market is one is Avastin, we have been using for years together from somewhere around 2005. Ranibizumab, which is available as Eccentrics, which is an innovator product. Then we have two biosimilars, Razumab and Vizumab. I don't think so anybody, because Reliance, they have marketed it, but I don't know anybody has used it or not. So I'm not talking about Razorel. What are the experiences? So the two available biosimilars are Razumab and Vizumab. We have good experience with Intas biosimilar, but Vizumab has been launched just a month back, so we don't have much of experience. Eylea and Peginex are other two drugs which are available in the market. The indications are neovascular AMD, DME, and vascular occlusion. Again, what we were discussing, I have put up into this slide. After safety, first is the safety, then comes the efficacy. And the best way to check the efficacy is give it in a RVO patient, and you will, or a CRVO patient, you will see the edema subsiding within a day. So if it works in an RVO patient, that means it will work in an AMD patient and also in diabetic macular edema. So my thing is what Dr. Saurav said first is the safety, or what Dr. Somil said, safety first. I'll look into my preoperative patients and an NVG patients. Then I'll choose an patient of an RVO and see whether the drug is efficacious or not. Uh, what is important, whether it's a type of anti-VEGF or number of injections. I give a list of patients when I do a counseling. I said कि these are the drugs available to you. Now patient says कि डॉक्टर साहब ये आइडिया लगवाना है, ये 60,000 का इंजेक्शन है, ये और इंजेक्शन से ज्यादा अच्छा काम करेगा, तो एक ही इंजेक्शन में हमारा वो बीमारी ठीक हो जाएगी. But no, that is not the answer. It's the answer is number of injections. It's not the anti-VEGF which matters. It's the number of injection which matters. And we'll see in subsequent slides that number of injection is key to the success of visual outcome. And this number of injection adds on to the financial burden, what Dr. Somil and Dr. Lalit has spoken. Coming to neovascular AMD, we know the landmark trial, which was Marina trial, and it was a monthly dosing for 2 years. And the results at 12 months follow-up was 95% had improved or stable versus 62% of control subject. More importantly, 34% had at least 15 letter improvement that was maintained over 2 years. But again, the problem here is continuous monthly treatment for 2 years. I don't think so with Eccentrics or Eylea or with any drug will achieve this target of monthly dosing schedule. So to reduce the number of injections, then came the Pronto trial, 3 loading doses of Lucentis followed by PRN. Results of visual acuity remained same as Marina and Anchor, but the average number of injections decreased. So in Pronto, the number of injections decreased and the mean visual acuity improvement was 9.3 injections. Another trial for AMD was CAT, which was a head-to-head comparison between Lucentis and Avastin, and it was the secondary outcome of this was monthly versus PRN. So if we see this graph, monthly bevacizumab was non-inferior to monthly ranibizumab. Both the groups had 8 versus 8.5 letter gain respectively. PRN bevacizumab was non-inferior to PRN ranibizumab, 5.9 letter gain versus 6.8 letter gain. But Lucentis showed trend of better response or better drying up on OCT, but the visual recovery was almost same. What we conclude from this is number of injections are important, not the agent. So monthly injections had a better result as compared to PRN injections, whether it was Avastin or Lucentis. So you have to give at least 9 to 10 injections a year to maintain good visual acuity. Uh, Diabetic macular edema, again, pan-VEGF blockade, Avastin more economical, but safety issues. Eccentric is the gold standard. Razumab or Vizumab gold standard and are cost effective. Eylea works in the patients where the vision is less, and if you combine with laser, the number of injections goes down. If we see DRCR net study, which was head-to-head trial between alpelisib, bevacizumab, and ranibizumab, what we see here was the gain in a letter was almost similar in all the three groups. Avastin group had little gain, but the important thing here, what you see here, the number of injections. First year, the number of injection in alpelisib group is 9, in bevacizumab group is 9.7, and ranibizumab group is 9.4, meaning thereby every patient of diabetic macular edema or central involving diabetic macular edema will require somewhere between 9 to 10 injections per year, which is a huge financial burden on the patient. At the end of 2 years, protocol T results, and the difference in visual outcome was almost same, that is 12.3 with ranibizumab and 12.8 with alpelisib. Uh, if we see 2 year study, again, in first year, you can see there are 9 to 10 injections were required. Second year, you see 5 to 6 injections are required. So it's a continuous VEGF inhibition, which tends to improve the vision. It's not one injection, it's continuous VEGF inhibition, which will uh, end up in good visual acuity plus a good diabetic control. So all three anti-VEGF agents on average produce substantial visual acuity improvement by 1 month, sustained through 1 year. On average, greater improvement occurred with alpelisib, but relative effect varied by initial visual acuity. At the end of 2 years, ranibizumab and alpelisib was almost similar. Bevacizumab had lesser effect reducing macular edema than the other two agents regardless of starting acuity. Few eyes in any group had substantial visual acuity loss. Median number of injection, what we have discussed, 9 to 10 in all three groups in first year and 5 in second year, and third year, fourth year and fifth year studies are also available, and they say at least 2 to 3 injections in third year, fourth year and fifth year. Coming to branch vein occlusion, this was a LEVO trial where they compared ranibizumab, alpelisib, and bevacizumab for macular edema secondary to central retinal vein occlusion, a randomized clinical trial. And you can see bevacizumab was not non-inferior to ranibizumab. Alpelisib was non-inferior to ranibizumab, meaning by bevacizumab had slightly lesser results, but alpelisib and ranibizumab had almost similar result, and there was no statistically different difference between the two groups. Uh, in the brighter study was a combination of superior improvement in BCVA with ranibizumab plus minus laser compared to laser group. So if you see the only laser group, the improvement was less. But in the group where the adjunctive, that is the yellow line, the adjunctive laser treatment was given, the number of injections were less, and the visual gain was almost the same as compared to monotherapy. Comparing the price of the available drug which is available in the market, all the biosimilars, if we see the cost price of Vizumab is 8,200, and if you need 9 injections, it will cost somewhere around 72,000, as compared to Razumab, which is 10,840, which will cost somewhere around 94,000, and Eccentrics is costlier. So once you are choosing a drug, and if you are giving a repeated treatment, cost is an essential determinant for the patient to continue the treatment. If the cost is exorbitant, usually because these patients, diabetic patients or AMD patients, are suffering with multi-systemic disorders. A diabetic patient has to go to a nephrologist, has to go to a diabetologist, has to go for a diabetic foot. So he has a gamut of physician in his line, and every week he has to visit one physician, and that adds on to the cost. And with the OCT cost and the surgeon cost, each I think patient will be spending somewhere between 15 to 20,000 for his vision. So limitations with Vizumab is it's a new launch, no peer-reviewed publication available. Uh, we are gaining personal experience, has used in 2 patients. Safety and efficacy appears to be satisfactory. I have given in last 2 weeks, so I cannot comment about the long-term safety. Need more data and personal experience to convince all of you, yes, this is a drug which is comparable to Razumab or to Eccentrics. To summarize, every disease, neovascular, AMD, DME, vascular occlusion need sustained VEGF inhibition. Choose a drug which is financially cost effective to the patient. If patient is covered under various schemes like CGHS, ECHS or PSU, patient usually brings the vial along with this, then choose according to the available data. Single dose preparation is always useful in panel and insurance patient. Preferred drug of choice is Ranibizumab, Razumab, Vizumab, or Eccentrics. In select group of patients like PCV and DME, where vision is less than 20/50, Alphabet is the drug of choice. Thank you very much.
Thank you, Avnindra, for a very comprehensive talk. And you have given a very, very beautiful idea of how to go about using biosimilars. We have used some Ranibizumab, which is made by Reliance. And we also found that the box of the Ranibizumab is the same as the Vizumab. So obviously the same guy is making for both the Reliance company. And we have not had very great results. We used about 10 or 12 of Ranibizumab and not had very great results with Ranibizumab. So
Mohan?
Yes.
No, I believe Cipla has outsourced to the same Reliance manufacturing. Reliance has the manufacturing part. So they're using the same lab and getting it, and they're giving it cheaper than...
I know, they're giving it cheaper. Yes, that I know. So packing, if you see the packing, it is exactly the same.
Sir, actually the DCGI approval for the drug is from Reliance side. Cipla is only the marketing agency for Razumab. So the DCGI approval is given for the Ranibizumab, which is produced by Reliance.
No,
the data what they will be showing is of the Reliance data, not their data.
The 16 centers what they have chosen is all done by the Ranibizumab group, so the Reliance group. But I just wanted to ask you, have you had any experience, or I'm not going to ask panelists, Dr. Natarajan's opinion also, Soumil's and Saurav's also, whether they have an experience with the Ranibizumab and how effective it is, how safe it is, and how effective it is also. Leave alone the cost. Leave alone. We are talking about safety and the efficacy profile.
Ranibizumab
and Have you used it before?
Yeah, I used it. I used it because Jaydeep uses a lot. My consultant in hospital, Jaydeep, he uses a lot.
Now, what is his feedback?
It's good. Only one patient, because when they posted for one patient, I was like, how did you post here? I don't know what is it. Then Jaydeep said, no, sir, I've used 4 patients and you can safely use it, he told me.
Yeah. Somil, what's your take on this?
Sir, I haven't used it extensively. I have used it only in 2 patients so far. And the reason why I have used it is because a patient got the vial with him. Because he was in Reliance, and I don't know whether it's a common practice there, but they had given the vial to the patient when I had prescribed anti-VEGF. And I said that with your responsibility, I'm giving you this because I'm not sure about the sterility, the safety, efficacy issues. And he was quite confident. And I injected both the patients were BRVO patients, and they both did very well with even ranitidine.
Okay.
So there was significant.
Saurav, thanks, Somil. Saurav is there?
Yes, sir. 2 patients, good efficacy, 1 month, good response. I got samples of them, sir.
I have not used it till date, sir.
I have not prescribed myself, not available in our hospital pharmacy.
We used about 10 or 12 till now, and we have not had very great results with that. I want to stress one more point, that Razumab, which is made by the Intas company, with of course it works very well, but the pre-operative, when we give the Razumab, absolutely there's no angiofibrotic reaction at all. The vasculature is still the same prior to vitrectomy. I do not know whether you had the same experience with other groups as well.
I have found it to be quite efficacious. I have had good experience with Razumab as well, even when I've used it pre-operatively. I don't know how much of a gap do you give before you enter for
3 days.
surgery? 3 days. Okay.
3
So
days.
same with me as well.
Yes.
48 to 72 hours.
Yes.
So I think it should show signs of angiofibrotic switch right then.
So surprisingly, we found that in a few patients of Razumab, we were not able to, and still it was bleeding like hell. And we found that Razumab, but when we used the Avastin, okay, nowadays we're using Avastin for the pre-operative, only for the pre-operative cases, we're using the Avastin now. So coming back to Avnindra, I just wanted to ask you, because there are a lot of apprehensions about switching over to a new molecule, okay? People are used to accent rates because they know the efficacy, the safety profile, and they have burnt their fingers. Many of them are with Avastin. They have had a bad experience with Avastin. So when you want to switch over to a new product like a Vizumab or something like that, what are the things you will keep in mind? You will straight away switch over, or you will do something like I don't know how you will.
No, sir. First thing is what I have mentioned in my talk also. First thing is the safety issue. Whether it's giving any immunogenicity or any kind of reaction. And the best way is to test is you go for pre-op patients. Second thing is you choose patient whose vision is less and you see whether there is a reaction or not. Then comes the efficacy part. To check the efficacy, what I want to see is RVO patients are the best patients. Because RVO, if you give injection anti-VEGF, the edema subsides within 2 or 3 days, and next day you do the OCT, you will find almost a flat OCT. So
but
if you...
AG, the issue is, RVO, I have the best prognosis also. You see,
So,
I agree. RVO, what I published a couple of years back, that one day wonder. You see, before I reached the OPD, patient got an OCT done, and OCT from, you see, more than 1,000 came down to 300 or so. So that was the happiest patient. But RVO have faster resolution, but
that means that the drug is efficacious, because in diabetics it's multifactorial. The control, whether the patient is responsive to the treatment, whether the inflammatory element is there. So you can't come to a direct conclusion whether the drug is working or not. So RVO will give us
let me ask one question to you. Once you do your first patient, what are you going to ask the patient? Sort of, because I know, suppose you are planning an RVO patient on Monday or maybe Tuesday. So what do you tell the patient? I'm going to try another drug. consent is very important. How do you talk to a patient?
Yeah.
I have already counseled a patient of mine. He is a very intelligent school teacher, and I'm giving him next week my first Vizumab. He is not very well off, no insurance, nothing. So I told him I told him about Cipla around a month ago when they first came along, and I kept telling him the Cipla story again and again. New medication, I'll get a free vial. So he's all happy to have the free vial. I've counseled him for a month now, and he's read on the net. He's found everything out. I showed him the box last week when he came for a checkup. He's scheduled for injection next week, and he's totally sold on that. I know this is negative, positive. I don't know what kind of counseling this is, wrong or right, but
No,
I want
Mohan,
to slowly.
I've used it.
One second. My issue is,
yes.
You see, Avnindra, Rekha, all of you have now a lot of experience with Intas biosimilar. Okay.
Yes.
We have experience. So, sort of, will your patient, are you within your conscious say that I will inject this one which I have no experience vis-a-vis the other biosimilar which have experience?
No,
so
sir.
That is the issue. You see, how do you talk?
That is the issue.
My problem is I have a lot of difficulty in talking. You see why, even though you may say I am doing free of cost for you. So issue is to bell the cat. Rekha, how do you bell the cat?
Yes.
Rekha?
Sir, we did that clinical study where it was double blind. So we were giving both Lucentis and biosimilar injections.
Yeah.
So not any major issues we felt, sir. Only one patient had a syncope, and that was again, it was concluded that not related to the biosimilar study medication.
So,
So
Samuel, your thought on this? How do you talk?
Sir,
Apart from previous experience.
So what I do, the strategy is to reduce the cost to, see, I give it to non-affording patients. That's the first criteria. The second thing is I tell them that compared to an off-label injection, this is a BCGI approved injection, though it is new in the market. So it does not suffer from the inherent side effects that probably an aliquoted drug would suffer. I'm giving it to you at a lesser cost than the aliquoted drug because I cannot vouch for its efficacy right away. But there are ample studies that have proved that this drug is very similar to the parent molecule that is there. So this is the way I counsel, and it is usually the cost issue that the patient has.
If I am your patient, believe me, if I am your patient, I'm going to say, Dr. Sahab, cost ki baat nahi. A lot of poor patients tell me this, sir, cost ka issue nahi, meri aankh theek rehni chahiye. You see, this is what is the challenge. You see, I agree with your first part. I will tell him that this is an approved drug. It has been approved by Government of India. Once I tell him that it is approved by Government of India, and if I say, and if you are the first one to try, that will negate. So I will never tell him that you are the first patient to be tried upon. So I will say this is a new medication which has come, approved medication, so I am giving you.
Yes, sir. So I agree with that. And Sara, sir, please.
I agree with what Samuel just said. It occurred to me, it's a very encouraging thing to say that this is superior to Avastin. And I can touch my heart and say that.
Yeah.
This is superior to Avastin. I think you have to comparatively explain to the patient what is good and what is right or not. So I think
that's a good point.
It's better than Avastin. It's a very correct fact.
Yeah, Doshi, what are you trying to say?
Yes.
This lady is trying to say something. Jinal
Doshi?
Sir, I just meant if we can move to the next speaker because it's...
Yeah, we will finish in time.
We'll go to the next speaker.
No problem, sir. Thank you.
Don't worry.
Sir, actually,
there's a more of a panel discussion here.
Sir, there is what Cipla is telling us ki they are now in process of producing this drug, and the Q&A, the quality control is being controlled by Cipla. So they are saying rest assured with the quality what we will be bringing in the market, but that has to be confirmed by the panel of doctors.
AG, one thing I'm telling you is this word of mouth does not matter here. You see, if the word comes from A, B or C, maybe Mohan is more reliable than Lalit Verma, that's okay. But you see, in terms of anything which is going inside the eye, so we have to have evidence. Yeah, I told Cipla people that Reliance ka molecule hai and you are marketing it.
Yes.
Reliance is not known for pharma. Reliance is known for, you see, other things like high-tech things and 4G and other.
Sir, Reliance is one of the biggest marketer of biologics.
Yeah. No, but
Reliance Biosciences, and I have been using their Relisil from long time back.
So
it's somewhere around 11 years back I have been using their Relisil.
Okay. Yes, Saurabh.
And I accept what Avnindra is saying, and I understand what he's saying. But again, the passingly what was said, CIPLA has no role in this. Quality control, nothing. They have not promised. They are not even opening and checking what is there inside that. Whatever Reliance is giving them, they are just marketing. Like what Mohan said, packaging is the same.
Yes.
They have no efficacy tests, nothing that they are doing to this. I wish they were.
Mohan, when will you start using Vizumab?
I already started using Vizumab. I've done it in 3 patients.
Okay.
But I will choose. Avnindra's talk is very, very, enlightening talk, I would say. We'll use it in patients who got fairly poor prognosis. So reduced vision, and these patients probably may be the starting point for you. And you can always tell that this is an approved drug. Somil said it very correctly, approved drug, and it is better than Avastin. And also CIPLA has got a very good track record. Please understand. They may not have a track record in anti-VEGFs, but they got a fantastic track record as far as the ophthalmic drugs is concerned. They got many people, even Ciplox, on other antibiotics or whatever, the range of medication, many people are aware of the CIPLA this thing. So I think
meaning thereby Mohan Rajan can never have PCR. What I'm trying to say.
It's not that. Please understand. It's not that. If I have a PCR, I can manage it better.
Yeah.
Yes, I can manage it better than anybody else. That's what I would say.
So I agree with the three points. One Samuel and one Saurabh said, and one you are saying, and AG also said that track record is very good. It's better than Avastin, and it's approved drug. I think once we start, this is the way I'm going to counsel.
Sir, there is an important information right now which Snehal has just put in over here. She's made a point that Saurabh sir in the chat box, CIPLA does all quality checks before we get the batch of biosimilar.
I would like to ask, how do they do quality check?
You see, she has made a statement here. Snehal, please speak up.
Box is exactly the same. How do you do the quality check? And they have done the quality check is done by the Reliance in the 16 centers. They have chosen. The Reliance has done it for the Ranuriziral.
Other thing which bothers me, Samuel, and we showed that comparative chart. Reliance is selling the same Dibbi, higher cost, and they are selling it at lower cost. So who is absorbing the difference, or who is cheating us?
Natti's opinion I want. Natti?
No. That is why I called, because when that sample came, I said, how can you just send a sample of the intravitreal without sending me the details of the study? Then they send me. Then they call the company, ask, how do I rely that whatever you have done is good? So one of the things, as Mohan, you said, CIPLA has a unit in Goa, and I remember, I don't know whether I went with Lalit or there.
I was there.
We both went. You only took me, I think. And when we went to that unit, I think because I know the owners, they are in the gym with me, the Hamid family. So what I'm saying, their products are excellent. But here, I was a little shocked yesterday that they are doing it. I don't know, where is your unit? He's saying, no, we are not bought a unit. They're using the Reliance unit. So I don't know. How they will do a quality check, I'm not sure.
So let's.
What I want. Somebody can from Snehal, or somebody can talk from the CIPLA side.
I think let's move to Dr. Rekha first, and after that we'll come back to discussion.
After that we can have the talk. Yes.
You see, let's do justice to the entire session. And I know a lot of interesting points are going to come up. You see, my ultimate aim is our patient should benefit.
Correct.
And I am willing to, go ahead and start injecting Vizumab, provided within bold capital letters. We know it is going to be safe, and safety is of, as AG said, Samuel, Saurabh, everybody said, that safety is of paramount importance. And the day, believe me, it turns out to be safer and equivalent to Razumab, then I think this will become, as I showed my slide, #1 biosimilar as of now.
What Lalit, one more point is whether the CIPLA employees will take for their own parents, even if it is given free.
Yeah, I know. I have already spoken to them. Dr.
Yes.
Rekha, can you start sharing your presentation?
Yes, sir.
Very interesting discussion going on. and I'm happy that